Good afternoon, everybody, and a very warm welcome to the annual general meeting for Staffordshire and Stoke-on-Trent Integrated Care Board. We hold our annual general meeting annually to share our annual report and accounts and give the public a clear view of our performance and future plans. And it provides an opportunity to answer any questions that members of the general public may have of the working of the ICB. The period that this annual general meeting is covering is the year 24-25, and we will run through the agenda shortly to just set out how we are going to conduct the meeting tonight between 5 o'clock and 6:15. Just in terms of meeting etiquette, all cameras should be off except for those presenting items on the agenda. Please make sure your microphone is on mute during the meeting. Questions submitted via email in advance of the meeting will be addressed during the question and answer session towards the end of the meeting. And when appropriate, please raise your hand on Teams if you'd like to ask a question live during the section of the agenda where we'll cover those questions in detail. The meeting's been recorded and will be uploaded on the ICB YouTube account and added to our website. If we could just move to the Leadership Compact. The Leadership Compact is a document that's used extensively by the Integrated Care Board. It guides the way that we conduct our business, and we will return to that at the end of the meeting. So in terms of tonight's agenda, we can just put that on the screen. We are going to go through a presentation by the executive team covering on a number of key areas that you can see on the agenda. Then it's great that we've been joined by Karen Webb, Deputy Senior Responsible Officer for Learning Disability, to join us to share with us a case study around Ed Davies' story. So we'll pick that up at that time and then move into Lynn Miller, who will do a forward view, and then we'll have a public question and answer session at the end of the meeting. So Paul, if I could hand over to you.
Thank you.
To take us through the first half of the meeting.
Thank you, Chair, and thank you for your introduction about this is looking back at 24-25. Title I've got System Evolution, so I'm going to be slightly naughty, Chair, and I'm going to do an overlap from 24-25 into 25-26 and where we're going. So next slide shows the Integrated Care Board strategy on a page, just to remind us all of that. I go back to this quite often. In many ways, this is my moral compass that I use as I do an awful lot. The 5 Ps that we started the ICB with around people and communities, personalised care, personal responsibility, prevention inequalities and productivity. And I go back to that quite regularly, talk about those 5 Ps. Then the next slide. Reminds, right, I've lost. We're going to get different slides coming up now. So we've got the diagram on that one, the next one. That's my diagram. No, go to the next one. No, okay, go back. Go on the next one. So the system operating model that we've had for the last year has been very much about our portfolios, our place, and our provider and system collaboratives. So our portfolios are clinically oriented with a system-wide focus. The place involves NHS, local government, providers of healthcare, and then obviously our collaborative partnerships bring agencies together. And you can see on the side there just an explanation of those 3 things. And that's been our operating model all the way through: portfolios, place, and provider system collaboratives. Next slide shows us the portfolios. Just a reminder of the portfolios we've had during 24-25. Some of the names on this change as we go through the year. But you can see 7 portfolios, and on each of them we've had an exec sponsor, SRO, portfolio director, clinical director, and they drive an awful lot of the work that we've done. I'm now going to start to go across into 25, 26 and beyond. So looking forward into this year and then into next year, we're looking at the NHS reform and reset agenda. 1st of April this year, 2025, it was announced that NHS England, Department of Health and Social Care were going to come together in a single unified aligned centre. And from that, a number of things then fell out in terms of requirement for ICBs to reduce their running costs. The number of ICBs is reducing, 42 to 26. We've had the 10-year plan, the DASH review. We know commissioning support units are going to be wound up, changed roles for all of the different structures within the organisation, within the system, and some functions may move. So a lot of change in there in terms of that evolution. Go to the next slide. So in terms of strategic commissioning, so the ICB model blueprint clearly established strategic commissioning as the central focus for ICBs of the future. And very clearly on there, it tells us strategic commissioning is looking to improve population health, reduce inequalities, improve access to high quality services. And strategic commissioning is the key to those 3 shifts that we've got to do in the NHS. And it's got a nice phrase at the bottom about making sure that the expenditure is focused on the highest health need with the most effective intervention in the most cost effective location. And then principles of strategic commissioning down the right hand side, and there are 7 of those just listed down there. I'm skipping quickly through this, Chair, but just to keep time. Next slide. The next slide's got the 4 parts of the strategic commissioning approach. Understanding our local context, what are our population needs, developing that long-term population health strategy, then delivering it and then evaluating input and going round that cycle. And then you've got the 8 enablers. If I can just go back, this is my final slide. I'm going to hand across to Elizabeth, just to say, when it talked about strategic commissioning, Chair, improving population health, reducing health inequalities, improving access to high quality services, it makes the point that this means effective decommissioning of services too, using data and intelligence to evaluate impact direct resources. I think that's something as an NHS we are not particularly good at, is decommissioning services and reprioritising what it is that we need to do. And I think we've really got to have a focus on that as we go through about how do we reprioritise, decommission, and then really commission and look for the things that have the greatest impact. I'm going to hand over to Elizabeth there.
Thank you, Paul. Good afternoon, everybody. I'm Elizabeth Disney. I'm the Chief Transformation Officer, and I'm going to just take you through a short presentation highlighting the achievements in 24-25 related to our community transformation work, and then I'll just go on to talk about our provider collaborative. So if we can just pop onto the next slide, please. So for us, community transformation has been about delivering some of what Paul's actually just been describing. So more proactive care, responsive to the needs of people, ideally based in their homes, if not in their homes, very close to their home. And of course, it's really important about specialist care we provide. But for us, community transformation has been about achieving that. And throughout the work that we've done that's been reported on in the annual report, we've had that real focus on those proactive care models and what's called a left shift to help improve health outcomes and essentially prevent the need for attendance and admission at hospitals when people's health conditions worsen. So we're trying to avoid that wherever possible. And in the annual report, there's lots of examples of work that we've done as a system and as an ICB, as a commissioning organisation, focusing on end-of-life services, long-term conditions, and responding to our population that might be frail and have needs that mean we need to be able to respond quickly to keep them well and independent. So the work that we did last year delivered through our end-of-life long-term conditions and frailty portfolio did much of that for us. And then we did a lot of work as a system, thinking about what are our principles, what kind of services do we want to deliver. And I'm going to pop onto those in a moment. But before I do that, I just want to mention our approach that's underpinned this, which is using population health data. And we've really, what that is, it's where we look at lots and lots of linked data sets relating to the health service utilisation or the health status of our population. And what it means is when we put all that data together, we can start to look at it and identify groups in our population that are likely to need proactive care to prevent their health condition from worsening. So we've been really looking at our data sets in 24-25 to think about how can we understand what outcomes we're currently getting for our population and how do we need to improve our health service offer to improve those outcomes. And some of that's about thinking about how do we need to, on an ongoing basis, and we started this work in 24-25, we've been doing more this year and we will have to continue to do more as a system in terms of shifting investment into communities, into services that are provided in people's homes, and using the population health data, we're able to do that. It also helps us to be really, to have a strong evidence base and track our impact. So if you imagine looking at data at the beginning of some work, thinking about services that might need to change, looking for new outcomes, and then re-evaluating and reviewing that data, you can start to measure your progress through kind of an evidence-informed approach. So our work in the space of community transformation has been hugely influenced by taking that population health data approach. So we can just pop on to the next slide. I just referenced a moment ago the key principles that our whole integrated care system agreed for this transformation work, this shift left, this proactive care that we labelled as community transformation. And these are some of the principles and some of the words I've already used that are really important that we agreed as a system. And it was critical for us to work as a system on this, because if you imagine achieving better outcomes for population groups requires a whole system to want to do that. It requires integrated working between some of our community organisations in the voluntary sector, as well as primary care, community providers, the acute. And so I don't want to miss any of our providers out, but critical that we did this work to agree these principles. And it really has underpinned the approach that we took in 24-25. If I just pop on to the next slide. The other kind of significant output we agreed in 24-25 was this real commitment to as much care in people's home as possible. So this kind of visual kind of interpretation of a kind of whole system and how a whole system might need to work together to provide more services in the home with some additional, increasingly perhaps specialised services wrapped around that. And then of course that real robust access to acute services has been something that we've been really working hard on. And we do believe the more services we can provide in home and in communities, responding to people's health needs before they start to feel more unwell, the better outcomes we can get people and their families, and the more we can kind of plan for a sustainable financial future. So I know Phil is going to come on to talk about the operational delivery in 24-25, which is definitely the interdependency and the interrelation with this work. But just before I hand over to Phil, there's I think one further slide just to talk on in terms of our providers, because the ICB is a commissioning organisation, it's a system convening organisation, but the whole system is made up by a huge number of providers, and in particular for us. The work at the Provider Collaborative, which is a collaboration between our NHS providers, local authorities, general practice, and increasingly, expanding into include further providers, made significant progress in working together during 24-25 on specific areas of work, which are at the time in 24-25 were continuing healthcare, clinical values and medicines, demand management, and contracting. The outlook's really exciting, I think, for provider collaboration. It has been this year and it will be for next year too. And as Paul did in his slides where we talked a bit about what we did last year, can't help talking a little about what we're doing this year too, because it's such a journey and such a development for our system. So there are 3 priority programmes that the Provider Collaborative are currently focusing on this year. And people will not have been able to escape the conversation about neighbourhood health for the NHS. So very much what I talked about before in terms of that community transformation work we did in 24-25, that has paved the way for the work we're doing this year on neighbourhood health, and the development of our Provider Collaborative has continued to do the same. So at that point, I am going to hand over to Phil, who's going to talk about the operational update. Thanks.
Thanks, Elizabeth. Good afternoon, everyone. I'm Phil Smith, Chief Delivery Officer. I just want to make a few points before I move through to the next slide and start to get into some of the operational detail. I think it's really important to note that the operational community across our system has continued to mature over the last year, and I think is now working to a really effective level to tackle not only day-to-day challenges, but also to deliver improvements when we look over the year, as we'll see in the slides we come on to, and to support development, as Elizabeth talked about, some of the longer-term strategies. The experience, I think, since we began in the ICB in 2022 has shown that when we look at operational delivery, the problems and the challenges often present in one organisation, the solutions involve the whole pathway, and it's really important that those solutions work across end to end, and that we really recognise the value of maintaining that system-wide view of delivery and operational improvements. So if we can move through to the next slide, please. So we're starting with some graphs, you'll be pleased to know. So from a planned care perspective, we've continued the really long journey in terms of recovery following the pandemic. We've seen real improvements in the timeliness of care for our population during 24-25. So I'll give you a few headlines. There's some numbers on there as well. But essentially 8% more patients started their treatment during the year compared to the year before, which I think is a really, really significant thing for us in terms of getting on top of those backlogs. More people are completing their treatment within the 18 weeks standard. And as the graphs show, we've seen real significant movement on our long wait profiles. So numbers of people waiting over 65 weeks for treatment has improved by 79% during the year, and those waiting over a year was also reduced by 57%. Important to emphasise here that this isn't just about capacity, this is about working differently, it's about looking at the whole pathway, and it's about productivity, making sure we're working as effectively as possible at each step of the journey. Key to delivering this is timely diagnostics. We've had a real focus in year on developing symptom-led diagnostic pathways. We've looked at gastro, liver, gynecology and breathlessness. So these pathways have been developed in collaboration with colleagues and most notably with clinical experts leading them from across the system. Can we move to the next slide, please? So in terms of cancer delivery, the evidence nationally is really clear. I probably don't need to say it, but I will. Long-term outcomes are improved by early diagnosis. Therefore, we've had a real focus on increasing awareness of symptoms and also supporting people to access care and diagnostics easily if they do experience these symptoms. So we have 12 separate campaigns during 23-24. We engaged thousands of people through these. Campaigns included skin, bowel, lung, breast, prostate, cervical, gynecological, so right, and other cancers as well. Particularly innovative was the Cancer Awareness Bus Tour. We've got a picture of the bus, which my team was really proud to share with the board earlier this year. The bus travelled the county, engaged with almost 6,000 people across 15 locations. We've received national recognition for this. And we're planning future tours as we move towards the end of the year and beyond. Another couple of graphs here on the other side of the screen. So for those people who are on cancer pathways, we achieved the 77% faster diagnosis standard, and patients beginning treatment within 31 days of diagnosis also improved to over 92% during the year. Can we move through to the next one, please? So nationally, from an urgent care perspective, we know that 2024 was the busiest ever year for our emergency departments and emergency services. Locally, we saw between 4 and 6% increase in demand year on year across the various portals for our population. It is encouraging that despite this challenging context, we did see improvements across the pathway with a 12% reduction in ambulance response times, meaning that those who need that urgent care are getting it much quicker. And we also saw a small improvement against the 4-hour standard, and we have seen continuation of improvement on that as we've headed into this year. The demand profile, The ever-growing complexity of patients and spikes in infections over the winter period really did place considerable and sustained pressure upon our services, and there were unacceptable delays for our population, particularly over the winter months. Our operational teams worked tirelessly to maintain high quality care. Within the ICB, we have our System Coordination Centre, which has been externally assessed as amongst the most mature in the country. That works 365 days a year, 10 hours a day to manage that flow across all parts of the system. It's also supported by our emergency preparedness and response teams to support us with periods of escalation. We've carried out detailed learning events following the winter period in particular, and as we presented earlier today at our board, these have been used to inform how we plan for periods of surge going forwards. We can go to the next slide, please. During the year, we carried out extensive engagement with our local populations to understand their experiences of accessing services, to improve awareness of the offers that are available, and to support developing our long-term approach for those communities. We refreshed our system urgent care plan, ensuring that there's adequate focus at all parts of the pathway. A couple of things I'll just draw quick attention to. Firstly, around admission avoidance, we established our integrated care coordination centre in September last year. This is essentially, I term it as a one-on-one for care professionals, a single point of access into the various care offers in our system to support people receiving care where they need it and to avoid unnecessary conveyance to hospital. Since that time, I'm really pleased to say that we've had over 41,000 contacts from care professionals into that service. We were the first system nationally to implement an overnight offer for that single point of access as well, which has been really successful, and we're planning to grow that further as we head into this year with more links back into our communities to drive care closer to home. Pathways and processes are really, really important. To that end, University Hospital North Midlands invited NHS England in partway through the year to undertake a thorough review of processes, clinical pathways, decision-making processes, etc., which has led to a really detailed improvement programme that's been deployed during last year and into this. And from a discharge perspective, we expanded our integrated discharge hub, further development of innovative offers, and what I'm particularly proud of, again, so proud that we put in the bold at the bottom, the support that we received from Staffordshire Fire Rescue Service around helping patients get home, get settled in. Over 2,600 patients during the year received this service. So we've seen continued progress as we've gone into this year with the key performance metrics, but linking back to what Elizabeth was talking about, our solution is not about doing more and more in the hospital. The solution here is really in terms of transacting the less shift, realising those transformational opportunities in our neighbourhoods and delivering more effective care and outcomes closer to home. And that is where the operational community needs to focus as we move forwards now in terms of actually transacting and delivering that. Thank you. I'll now hand over to Claire.
Thank you. Good afternoon, everybody. My name is Claire Finn. I recently started as the Chief Finance Officer for the ICB in July. As a part of my role, I'm required to ensure that we keep proper financial records and comply with appropriate financial reporting requirements. This includes the completion of the annual set accounts and delivery of financial performance. If we can go on to the next slide, please. Thank you. So in 24-25, the total spend of the ICB came to 3.2 billion, broken down in the areas shown. In addition to this, our NHS provider trust based in Staffordshire and Stoke-on-Trent also received 1.1 billion of other income from other ICBs and different sources. This means that the total resource available to provide services to our patients in 24-25 is 4.3 billion. If we move on now to how we performed in 24-25. So I'd like to draw out 5 key financial targets which the ICB are measured against. So the first one being that we are not expected to exceed our management costs set out by NHS England, and I'm pleased to report that we underspent by 0.6 million. We are also not expected to exceed our revenue resort limit as set out by NHS England, and fortunately we did exceed this by 14.9 million. We're not expected to hold significant cash balances at year end, and these need to be less than 1.25%. This was achieved by the ICB. And I'm pleased to report that we also met the Better Payment Practice Code, which requires us to pay 95% of suppliers within 30 days. And finally, whilst this is still subject to audit, I'm pleased to report that we can demonstrate the achievement of the Mental Health Investment Standard, which requires the ICB to invest at least the same percentage uplift that it's received from its total resources. So I'd like to move on to looking forward to 25-26. So I want to draw out the fact that within our system plan, we've received 95 million of deficit support funding, and delivery of 25-26 in terms of our financial plan will mean we don't have to repay this in 26-27. As we did not achieve our 24-25 financial requirement, we have had to repay this in 25-26, which has led to a challenging in-year position and feeling more difficult. And we also continue to face other challenges of increasing demands, inflationary pressures, and we're also committed to driving down the waiting lists, as Bill has just articulated. As Paul and Elizabeth outlined earlier, though, there still remains a significant amount of opportunity to reduce down unnecessary costs and improve our patient care. So we will continue to have a strong clinical focus on ensuring that we've got the right pathways in place and processes in place, as we know from evidence that the best clinical pathways and patient outcomes will lead to a reduction in our costs and support our financial position. So we will continue to implement these actions in these areas to ensure that going forward we become a financially sustainable organisation and we provide safe care for all of our patients. I'll now hand over to Mish.
Hello, good afternoon everyone. I'm Mish Irvine. I'm the Chief People Officer for Staffordshire and Stoke-on-Trent ICB. If we could move to the next slide, please, Jess. I'm going to talk to you this afternoon about our progress throughout 24-25, but also looking forward into 26-27. In terms of the context that we're working within, it's safe to say it's an incredibly transformational context at the moment, both nationally and locally. We need to support and deliver the NHS reform and reset priorities set nationally, which impact on the workforce that are within the ICB and will also have an impact within our wider system. The 10-year plan has recently been developed, and we're expecting the workforce elements of that in November this year. From a local perspective, we have significant financial pressures, as you will have just heard. We also need to support the development and delivery of the 3 shifts, with the focus moving much more to prevention going forward. So what I'm going to do is take you through some of the metrics in terms of where we're at. If we look at those numbers, they're actually all really positive. One of the areas that we are focusing really heavily on is our sickness. 5.5% for our system is higher than we'd like it to be. And that's the focus of our People, Culture and Inclusion Committee in partnership with our NHS providers to understand what they're doing locally, but also what we can do at a system level to support the well-being of our workforce. If we move on, please, Jess. The next slide talks about the staff survey. There's some really positive news in this space. Our 24 staff survey results were the best performing system in the whole Midlands. That's significant on the basis that there are 11 systems in our region. We achieved the highest scores across all of the people promise themes. We increased our scores around safe and healthy, flexibility, morale, and we achieved the same scores for 3 schemes around being compassionate and inclusive, recognised, rewarded, working as a team, and engagement scores reduced, however, in a voice that counts and always learning. So some real positives there in terms of our NHS colleagues, but we need to move forward as a system into the next financial year, working really closely with some of our wider partners as well in terms of the flexibility and the well-being of our wider workforce. Now, the next slide's a little bit busy, and it just describes the achievements that we've made. Sorry, if we pop back, Jess, to the last one. Thank you. It describes some of the achievements of the last year in terms of the overall work of our people as a system. What we've managed to do is we've helped and supported people to enter careers by supporting them from deprived backgrounds, those with protected characteristics, and that's using our apprenticeship schemes, our T-level schemes, our Health and Care Academy. We've supported people to have an inclusive culture, both those individuals who work within the system, but also those that are going to join us. And that has been shown by our OD plan at a system level, by our widening participation and outreach programs. And you can see some of the stats there are really impressive in terms of the way that we've actually engaged with our wider population. In order to do that, we've tried to make it as accessible as possible and to make it easier for the majority of people to be able to access these schemes. So you can see that 5,000 young people have accessed our virtual work experience. We've been able to make specific programs for those with protected characteristics to be able to join our workforce. And that's what we're trying to do. That really supports our fourth purpose as an ICS. It's to really support the social and economic development of our population, to ensure that people prevent ill health by having a better quality life, by having a career that allows them to earn the money in order to live well. So the real positives in terms of the achievements from last year. If we move on, please, Jess, looking forward then into the next year, there are lots of challenges and transformative work that we need to do. We're obviously responding to the ICB reset in the people space and considering how best to deliver that from an ICB perspective, how we work with our regional colleagues to ensure the safe transition of some of the activities that are currently done at ICB level, but to make sure that we do not move from delivering our plan and being absolutely focused on the workforce safety and productivity to ensure that we can actually be the best for our patients and also financially. From a system people perspective, we'll continue to do the work around anchor employer. We'll really support around strategic commissioning and moving towards the 3 shifts from a people perspective, and supporting our NHS and wider partners from a convening perspective to ensure that we can get the best economies of scale for some of the programmes that really support our workforce. So thank you. I will pass to Heather.
Thank you, Mish, and good afternoon, everybody. I'm Heather Johnston. I'm Chief Nursing and Therapies Officer, and I'm just going to spend a few minutes talking about some of the work we're doing around quality and safety, or some of the work we've been doing around quality and safety over the last year. So if we have the next slide, please. We've started just in terms of our position. So our ICB quality strategy documents our vision to ensure that services provided are safe, effective, meet the needs of the population. We spend a lot of time working and focusing on quality and safety. It's a really key part of our work, and we proudly irritate where things are not clear and ask lots of appropriate questions about how we might move things forward. Everything we do is intended to complement the overarching ambitions of the system and fit with everything that we've already heard about today. Certainly helps us to ensure that we deliver the requirements of the NHS patient safety strategy. And at the moment, as we move through the transition period, we're working really closely with colleagues in Shropshire and Telford and Wrekin around how we can streamline and bring together the best of what we do between us. Our quality strategy was co-produced with NHS partners, and we work very closely together with all partners on all aspects of the quality and safety agenda, whether that be through committees or whether that be through reporting processes. And I think our strategy reflects the focused and routine quality assurance processes that we've got in place. And I say that without apology, but they are extremely well established, and we are very confident in the work that we do around quality and safety. And I'll expand on that in a few minutes. I've talked already about this strategy supporting the NHS patient safety strategy, the national strategy. But amongst that and within that, we are really proud to have been able to recruit 2 volunteer patient safety partners. This is something that was talked about right at the beginning of ICB, and it's taken us some time, but we finally have got those people in place. And we've also very successfully implemented the Patient Safety Incident Response Framework, which we affectionately know as PSERF, where all partners have now been accredited. And again, we work really closely with all of them on continued implementation. What we do with that is underpinned by a couple of coordinated learning events a year, where we look at what we've done and what we can do going forward. This has been particularly important over the last 12 months because we now started to work with primary care in the same area. And finally, on the strategy, it reflects our commitment to the NHS impact work. So this is about continuous quality improvement across the NHS, and was published in December 24. So this is all documented in our strategy. If I could have the next slide, please. It would be very easy to talk for probably 2 hours about the things that we feel that we've achieved and succeeded in from a quality and safety point of view. So we've tried to pull out a couple or 3 or 4 specific examples here. Anybody who's seen any of the board presentations will already be aware of some of the things that we've done, but also behind that, some of the challenges that we have. And what I'm about to say, I say without any element of complacency. There is no room for us to be complacent where quality and safety is concerned. So whilst this highlights some of our big achievements or some of our main achievements, what we're saying is we'll continue to do this going forward. So we're particularly proud about our quality impact assessment process. This has been recently independently reviewed at our request by NHS England, and they've provided as a report that details significant assurance, which is strong evidence that our process is robust and, importantly, as we go through transition, sustainable. And this is really, really important as we go through the transition into a new organisation to make sure that we keep our focus on the quality and safety of care. Our local maternity and neonatal system has continued to support providers to deliver sustained improvements, particularly in areas like induction of labour delays, where historically we've had a problem. We've worked really, really hard with them and actually made some significant improvements and watched our main local provider move from requires improvement to good in CQC ratings, and we hope that will be sustained. All age continuing care, also known as continuing healthcare, we've done some really focused work this year and seen a massive reduction of over restrictive care, which was historically evident across our area. There's also been a consistent improvement in end of life discharge processes and onward care as a direct result of continuous quality improvement and transformation, and that's done very much in partnership with all the system partners referred to previously. And finally in the list, although never ever going to be the final achievements, we're really, really proud of the ongoing work that we've done around leaders, so learning from the lives of deaf people with learning disabilities and or autism. We've really, really stepped up in terms of our leader achievement. We're no longer, well, we were right near the top of the pile in terms of progress and delivery. But equally importantly, as the performance aspect, we've made some really positive steps forward in terms of training sessions with our communities and ensuring things like breast screening and awareness of breast screening and other screening services are available for people with learning disabilities and autism. As I said before, impossible to capture it all, but hopefully a few really positive examples of some of the quality and safety assurance work we do. And I'm going to hand over to Karen Webb.
Not quite.
Not quite.
So you're going to hand back to me, Heather. Thank you.
Handing back to David.
So Paul and the team, many thanks for that presentation of the annual report and accounts and forward look. And just finishing off there, Heather, on the leader piece, I'm absolutely delighted to introduce Karen, who I said at the start is Deputy Senior Responsible Officer for Learning Disability, Autism and Down Syndrome. And at events like this, it's great to see the formality of the annual report presented, but it's really great to hear about the experience of people who are actually on the front end of experiencing our services. So I'm delighted that Karen's joining us. Karen's going to take us through a case study, which involves a young gentleman called Ed Daly, and look forward to hearing about Ed's story. And Karen, at the end of this, would you just thank Ed for giving his permission to use his story at the AGM tonight?
Thank you, Chair. As you say, I'm Karen Webb. I'm the Deputy Senior Responsible Officer, and I work alongside Elizabeth and many, many others. And it's a real great privilege to come along tonight and share some of the work that we're doing. This is by no means all of the work that we're doing, but we're particularly proud of Ed and his colleagues who have lobbied long and hard, us and our partners, around how they live their lives. I don't want to go into too much detail because I'll steal their thunder. So Ed leads the piece, but actually you'll see a number of Ed's colleagues and their families, and they'll tell you their story. So I think the video will tell us the whole thing.
Thank you, Karen.
I'm Ed Daly. and I co-chair the forum with Karen Webb. I'm very passionate about people with Down syndrome having a say in decisions that are made about them. We are today with the ICB for Staffordshire and Stoke-on-Trent, leading on including local people with Down syndrome in policy making and recognising us as a distinct group.
For us to really make change, we need to hear from the people who live in Staffordshire and Stoke-on-Trent with Down syndrome, because we might think we know, but do we really know? And until you get people together and you start to share stories and experiences, whether that's good, bad or indifferent, then absolutely how can you make sustainable change that makes a real difference to people? What the forum is for me all about is raising the awareness for people with Down syndrome who've got a very different profile to people with a learning disability. And it's about how do we start to make Staffordshire and Stoke-on-Trent the kind of place people with Down syndrome grow and flourish and achieve their aspirations and dreams.
The focus of the forum will be on health, education, social care, housing and employment, like the guidance under the Down Syndrome Act. Through the forum, we can all work together to start to make much needed and long overdue change in the region for its people with Down syndrome.
We would ask everybody with Down syndrome and their families to come along and have their say, whether that's with us in the forum or whether that's any other alternative form that they wish for us to consider. The more voices we have, the more experiences we hear, the more likely we are to be able to influence the wider health, social care, education system.
You really can make a difference, and together our voice is stronger. Thank you, everyone.
Thank you, Karen, and thank you, Ed. Okay, we're going to move on, if we can now, to tackling health inequalities, and I'm delighted to introduce Lynn Miller, Portfolio Director for Improving Population Healthcare, is going to take us forward with a forward look. Lynn.
Thank you very much. Hello everybody, I'm Lynn Miller, I'm the Portfolio Director for Improving Population Health. And I want to have a conversation really about how will the ICB and the NHS in general will be having an increasing focus on reducing health inequalities and prevention to improve the health of our population. So if we go down to the first slide, please. So health inequalities are unfair and avoidable differences in health across our population in different communities, such as learning difficulties, disabilities and Down syndrome, as we've just heard. It's driven by a number of factors. For example, it could be the access and experience of healthcare services. It could be the wider determinants of health, so the places that people live, the housing conditions, the education that they received, or it could be about their health, their lifestyle choices. And these factors need to be considered when we're looking to improve the health of our population going forward for those better outcomes for everybody. So within this context, the Integrated Care Partnership, the leadership of our system across the whole public sector, has launched the Health Inequality Strategy with the aim of improving health outcomes through prevention of ill health and tackling health inequality. It's very much an inclusive approach to support populations who experience poor access to healthcare. There are already a number of areas we've started to work with partners on to start reducing specific inequalities that people are facing. So, for example, we're working with Stoke City Council and we've invested in family hubs to support children who may face being taken into care. We're working with Staffordshire County Council around their Warmer Homes programme, using our linked data set to identify people living in fuel poverty who may have respiratory conditions and at risk of admission to hospital, and attracting national monies to be able to retrofit their homes so they are living in warm, damp-free homes over winter, and anything that would have exacerbated their conditions without that support. One of the things that we're also about to launch is our Health Literacy Let's Talk Health programme. In the NHS, we use a lot of medical terminology, and when we're looking at the 5 Ps around personal responsibility and empowering our populations, we need to provide information to them in a way that they understand.
So the health literacy programme is very much around how we provide information from a commissioning perspective, how we talk to our partners, how our frontline staff talk to people, and also the environments that we're providing health services in. I think health literate spaces where people can absorb information and really understand what it needs for them. Elizabeth talked about population health management. This is really our approach for identifying where the biggest health inequalities lie, in order to put local interventions in place to prevent and delay the onset of poor health. Good example of that is our locality improvement framework. It's a £1.7 million programme across the 12 localities in Staffordshire and Stoke-on-Trent. So this includes up to £100,000 investment into the 8 districts and boroughs and the 4 delivery localities in Stoke-on-Trent. We're bringing partners together already. We're running sprints across the whole of the county where VCSE, the local authority and primary care are getting together to review the data and identify those issues that mean the most to the local populations. We've already got some really good examples of where we're making change happen. We're just about to launch the programme in Tamworth, who have got a huge focus on obesity, and South Staffs, who are focusing on the older population. In terms of that shift to community, it needs to be measured. And one of the things that we're wrapping around the locality improvement framework is that health outcomes framework, so we can measure the change at scale systematically while delivering it at a local level. Finally, we often talk about outcomes, and really what that means is preventing ill health. Going forward in the NHS, as part of the 10-year plan, there'll be a huge focus on the treatment and prevention agenda. We're very good in the NHS at treating conditions and body parts, but actually the move is towards a more life course approach and a more holistic view on the person and their families and their households. On this basis, we've developed a prevention programme. The NHS can only treat 20% of a person's health, and so we've really worked with our partners to include all aspects of primary, secondary and tertiary prevention in that approach. And you can see we're working with the Police, Fire and Crime Commissioner to deliver the alcohol harm reduction strategy. We've developed an obesity prevention programme, capitalising on some of the new medications and weight loss injections that are in place to create a new weight loss pathway, which has just been launched this month in primary care hubs across the county, very much focused on a specific cohort of patients, but that will be rolled out over the next 3 years. But I think most importantly, it's not just about the medications, it's really that holistic approach. And we've wrapped around the primary care hubs holistic support through the communities I've described through the LIF, or the locality improvement framework, I should say, but also a specialised multidisciplinary team for those known as SWITCH, for those more complex patients. Tobacco is the third lifestyle programme that we've got in place. It's really important when we're talking about childhood mortality and particularly women's health, around how we can ensure that pregnant mothers are not smoking, and obviously there are implications around cancers going forward with smoking. So a huge programme of work underway around tobacco. And just finally, we've got 2 clinical programmes around heart disease and diabetes. This has particularly got a huge health inequality angle in terms of ethnicity, particularly around women from different ethnic backgrounds who suffer higher levels of stroke, heart disease, diabetes than the general population. And we've been launching a number of events called BEAT across the whole of the county. To date, we've screened nearly 3,000 people through the BEAT events for a range of heart conditions, and significantly identify patients that we can get into primary care and manage their condition. The ambition is to screen another 7,000 people and get to that 10,000 mark over the next 12 months, and I know that we'll do that. So very quick snapshot around the direction of travel for the NHS, but also around some of the things we're taking forward from a strategic perspective, but also on the ground.
Okay, Lynn, thank you very much. That brings us to the end of the presentational part of this evening's annual general meeting. There's now an opportunity for members of the general public joining us to ask questions. And if we'll also pick up any questions that may have been submitted via email. If you'd like to raise a question, please raise your hand. And if for any reason we're unable to answer the question fully this evening, we'll make sure that it is answered subsequently and posted online after the event. So if we could just invite any questions that anybody joining us may have this evening. Ian, welcome.
In practicing.
You've had a full day, Ian.
A specific question and then a general comment if possible. Where are we on drug and alcohol services? I know it's very much to the local authorities to an extent, but these cause massive problems within communities. Access to, because a lot of the agenda seems to be, criminality seems to be at the forefront. Drug and alcohol services aren't just about treating people who are criminals or potential criminals.
Thank you, Ian, for the question. Paul? Sorry,
Thank you, Ian. So I touched on some of the prevention programmes that we had in place, specifically the alcohol harm reduction strategy that we developed with the Police and Fire and Crime Commissioner. And yes, there is very much a crime angle to that. Our responsibility is to deliver the health interventions, working very closely with the local authorities around that. So the alcohol strategy will be launched in the next month or so, but we've already started to work on those programmes of work. So we've identified a senior responsible officer in Elaine Andrews, who's one of the directors at UH&M. She's got a passion in this area, and funding to support some programme management. So we're at the initial phases of that, and we're starting to, the first step will be to review that end-to-end pathway to see what we've currently got and those interfaces and how they interact with each other. There's a full needs assessment been carried out, and I'm happy to share it with you. It's a really good read, if you like, but it really does outline in how we're prioritising alcohol in this instance. And in terms of that prevention agenda, we've got the highest alcohol emissions in the whole of the country, so it's really important for us from many angles.
But that alcohol, it's cheaper to get drugs than a pint of lager nowadays, frankly, some drugs, and it does, it crucifies the individual. And but as I said, it isn't just criminality, it's behaviour, etc. It disturbs communities. So where are we on that? Because if somebody wants to come off a drug, for instance, there's no use saying you've got a 12-week wait for a service, because that's no good. They need immediate access.
So I'm not the lead for the drugs and alcohol and mental health in the ICB, but the complexities of people who take drugs are numerous, aren't they, in terms of homeless populations, our veterans, people leaving prison, and it's really complex. So we're working with Stoke City Council on the Changing Futures programme, which is around supporting that cohort. We've also had conversations with our colleagues in probation about how we can support people when they discharge from prison. So we haven't got a specific strategy around this cohort that you're talking around, but we've got all of our partners around the table working towards solutions.
Okay.
Thank you for the questioning.
Right, could I make a comment? Have we got other questions?
No, please do.
All right. When you're talking about health inequalities, I mean, the main reason for health inequalities, and it's the elephant in the room, isn't it? Deprivation, a society that's massively unequal, poverty. In Stoke-on-Trent, there's some of the worst deprivation in the whole of the country. I know of children that haven't got a mattress to sleep on tonight. Food bank usage is off the scale. Now, you can treat an individual when their health deteriorates, but the fact of the matter is, with those kind of indices, the health is going to deteriorate. A lot of these people don't use services, believe it or not, are very loath to use services. They see themselves as a burden on society as well, their confidence levels are low. How do you address that within a strategy that seems to be clinical, but there are underlying things there, You have to generate confidence within those communities as well. And if you've lived a life, poverty is drip. It's the Chinese water torture for people. You know, they haven't got the confidence of people around the table here or myself. So how is that being addressed? Because you'll be forever elasto-plastic if you just look at a clinical need when it presents. Is that understandable?
Thank you. So Elizabeth's going to respond to that, I think.
Yeah, so Ian, I won't turn around and come back again.
Okay.
But what I would, because of my phone there, but what I would say is that at a strategic level, we do a lot of work through things like our children's and family strategic partnership with both of our local authorities, whereby we've got executive and senior leads from across health and wider public sector services joined with the local authorities, looking at the complexity of the types, the impact of on health, on other public services of the kinds of challenge that you described. So what I'd say is at a strategic level, it's very much a conversation about how can we, as a multi-agency partnership based around our geography, start to respond to that.
Yeah.
And then how I'd say that then manifests itself in our health system is in some of the initiatives that Lynn's been describing. When we get around the table and say, okay, there's a specific issue with something, you know, an issue within a local population, and we start to look at what we can do there. So an example of that, I think, has been some of the warmer homes work that has been done. So that came because we realised, you know, at a strategic level, we had a significant problem around homes that were not well insulated, damp, children were coming to our hospitals with respiratory challenges. That was then leading to huge levels of stress for families, problems in schools. Strategically, that was being discussed, but what we managed to do was find a solution for how we would start to fund, as an example, warmer homes. I think Lynn's presentation was really clear in terms of we're doing some of this work. I think the future is about us doing lots more of that work.
Yes, sir.
Yeah. Okay. Thanks for the question, Sim. I'll just check with people joining online. Anybody like to pose a question to the board this evening on anything that you've heard at the AGM? I can see, is that Mariana? Welcome and thank you for attending this afternoon.
Hello, everybody. Thank you for a really great presentation. Thank you to all speakers. A lot of information has been shared. I'm interested in the integrated care coordination and whether you can share a little bit more information around that, how it actually works in practice, and whether the voluntary sector is something that is actually offered as a kind of support and solutions to your practitioners. Thank you.
Thank you, Mariana. So who would like to?
Thank you, Mariana, for the question. So what I would say is that, yeah, so the voluntary sector is integrated within both that and our integrated discharge hub in terms of opportunities for those that essentially a call centre that care professionals can contact to then direct out to spokes to community support. So that is done either directly from the team out into the sector or via that integrated discharge hub. I think there's much greater opportunity to grow that as we move forward. And I think we have to remember that the integrated care coordination centre is about managing escalation. And the real solution here, going back to Elizabeth's presentation earlier, is to build that sort of cohesiveness and response within communities in the first place. But absolutely, it is a vital part for us. Thank you.
Thanks for the question, Mariana. Any further points that anybody wishes to raise with the board this afternoon? No. Okay, just check again, Tracy. Nothing online that we need to address. Okay, if there's no further questions, can I thank? Sorry, Paul's got some. Paul,
David, can I make a comment rather than ask a question?
Please do.
Is that allowed?
Yeah.
So, Ian, I can't possibly follow what you said before, but David, I do want to recognise that this will be your last AGM. Ian gave you a sort of valedictory talk at the board. I just wanted to recognise on behalf of everybody, and I've got some comments from some of the non-executives who can't be here tonight and so on, just to recognise that you're standing down after 52 years service in the National Health Service. And I know we've talked about this before, you know, where did they all go to?
Yeah.
You know, you sort of look back and think, crikey, 52 years. You've been chair of this ICB since we started, and you've helped, as Ian said before, to steer us through some really tricky stuff. It's got trickier and trickier as we've gone on. You know, you would think it would get easier as you go through the 3 to 4 years, but it's got more and more difficult. I think one of the comments has been that you've always led us with a very compassionate, supportive style. I would add on to that, you've always had your finger on the pulse. You know, it's very much, you know, your leadership. You've been a huge advocate for equality and inclusion. You've chaired the People and Community Assembly. You've very much championed public engagement. You've strengthened our relationship with the Voluntary Sector Alliance, but also the wider voluntary sector. So a huge amount done there. And I think also you've been very supportive of the workforce. You've met many of the workforce, you've gone out and you've met many of the workforce, not just in the ICB, but right across the whole of the system. And I think one of your greatest strengths has been relationship management. You've managed upwards really, really well in terms of the region and national. You've worked well with our peers in the NHS. We've got colleagues from Shropshire, Telford and Wrekin on the call tonight and so on. You work really well across there. You work well across with all our partners, but you also work really well with the organisations on the ground and so on. So, you know, I think that's been one of the real strengths. From my point of view, David, I think you've been a fabulous chair. You've been a formidable leader. You've been a wonderful champion for our workforce. And you've been a great friend, colleague and mentor to many of us as we've come through. I know you've still got a few miles to walk yet on this road.
Yeah.
Not quite there yet. We will have an opportunity to say goodbye to you properly. You know, we'll come together, we'll have a proper event, say goodbye to you. But we did want to just note it formally at the AGM, just to say thank you very much to you. And good luck in whatever you do next, David. I'm sure it'll have something to do with cars, but enjoy it.
Paul, I was certainly not expecting that on the script, but thank you very much for the very generous eulogy that you just given me. Actually, there these roles are really special and privileged, and it's been an incredible privilege to walk the road with everybody around the table and many of the people on the screen. I can see you spoke of Telford, Shropshire and Wrekin. I can see Simon Whitehouse on the screen there. Hi, Simon. And we've got the ICB to a platform. There's a reset taking place that will take the clustered ICB to a new platform and hopefully to do even greater things than we've tried to do over the 3 years of operation. And in stepping down, it's been great to meet up with Ian Green, who will be succeeding me. Ian has my absolute best wishes for the future, and we will make sure that when Ian lands in November, some of those relationships that we've begun to really consolidate in Staffordshire and get some resilience behind will go forward. So my thanks to the board, my thanks to all of our stakeholders, and particularly thanks to all of our people, communities, everybody who was engaged and given me support and encouragement. Thank you. So it is now my job to thank everybody for attending the AGM this evening. Really great that we've had people who've given up their time to come and listen to a review of the year 24-25 and a forward look into the future. Annual report and summary can be found on the ICB website under our publications. And in the next few days, if you haven't enjoyed this enough, you will be able to go back and listen to the whole thing again on our website. So can I thank everybody for their attendance, and we will draw the meeting to a conclusion. Thank you.